Lisa Mason. I am originally from Atlanta, actually, and I went to vet school at Auburn and then moved to Florida pretty quickly after that. And I have been located in Central Florida now for about 10 years. And I got my certification at CRI for CCRT very quickly out of vet school, and then acupuncture trained at the Chi Institute right after that. So, and then I was kind of dabbling in it for a little while in an integrative practice, you know, before integrative practices became like the mainstream thing. And then I found that I really love doing rehab and partnered up with a human chiropractor who became my rehab assistant and opened my own standalone rehab clinic about almost at 4 years now. And then as of about a year ago, I joined in with the only national partnership of rehabilitation practices called VROMP, or Veterinary Rehabilitation Orthopedic Medicine Partners. So it's very exciting to be part of such a wonderful partnership. And I've had my PiezoWave now for, I guess I'm at like 3 years, because I met Cindy a little bit right after I got it. And my biggest thing when Cindy came to me with another piece of equipment was, I was like, I don't think I'm using this right. And she was like, well, there's not really a correct way or right way. And I was like, but I think I'm not using it right at all. And so we started talking, and then we were like, oh, we need to develop some training and some informationals. And so then that started our journey to really dive into the PiezoWave and the education on the PiezoWave.
And just kind of comparing the difference between the focal and the linear, and using it on myself, that I feel the focal is much more intense of a treatment.
What I have found is that the certain energy density on, say, an intensity of a 6 on the small focal head is going to be comparable to, say, a 12 on intensity on, say, the linear head. So you actually do increase the intensity. Now, the way that I use both of the instruments is I personally like to start at a 6. Everybody's different. So if I'm using the focal head, I start at a 6. If the patient looks to be uncomfortable, I drop it down. So by uncomfortable, I mean like they're wiggling, they're not sitting still. What I want to see is a small amount of lip licking, eye blinking, a little bit of something to tell me, like maybe a change in the breathing, that I'm in the right spot. And that's what I'm looking for. I don't want pain, but I want that response. If I'm not getting that response, I'm either not in the right place or my intensity is not high enough at that point. So that's what I use to decide my level of intensity for these patients. Now, when I'm using the linear, I find that the patients are actually a lot more comfortable when using the linear. When I'm using the linear, I'm usually treating a bigger surface area. So I want to try and get more distribution of the energy into the tissue. And so I'm usually using a bit more of a sweeping motion, more like a laser, versus when I'm using the focal head, I'm really kind of focused on one particular location. So I do bump that up. I usually stay around a 12. And I also, again, am reading my patient. But I really find that, like, if I have paraspinal trigger points that I'm working on, that this is a much easier way for me to get the trigger points out versus doing trigger point therapy specifically, where the patients are just plain uncomfortable. And this is so much easier to get that trigger point just to dissolve. So I love the linear for that. So a lot of my backs that I'll use that on. I use it for lumbosacral disease as well. And man, do those guys feel so good afterwards. I mean, it's just like, you see them, like you even see the tail carriage, you know, is different when they walk out the building. Like, it's just really lovely. I've got one that I'm treating right now. Before I started, had 0 anal tone. Like, literally the feces were dropping out of this dog's booty. And we have done, I think we've done 2 shock waves at this point. And I'm one of the types of people that does it once a week for 3 weeks and I reassess. But so when he came in the other day after the second shock wave, he actually had a little bit of anal tone and his tail was able to raise a little bit. So I was very, very, very pleased with that response.
Oh. Question in regards to hemilaminectomy cases, I feel really hesitant to use it because I don't really know when a safe time point would be. And of course, every dog recovers differently from that surgery, but what kind of symptoms would you look forward or to feel comfortable using the myoprobe?
Is that I typically am not directly over the top of the vertebrae when I am doing shockwave on the spine. So I'm basically treating the paraspinals.
Right.
So in that regard, I probably, let's assume that they did not put any equipment in there, which most of the time they don't, but I would assume like if we just like, we're dealing with like maybe a wobblers or something like that, or there was fracture or whatever. I'm hesitant to use the shockwave where there is some equipment in there and that it hasn't really secured itself or fibrosed itself in there, because the vibration of the sound waves, they potentially could move some of the equipment. And I've talked with this I've talked about this with an orthopedic surgeon, and we've talked about like, as long as we're going around plates and things like that, then we can kind of aim, because it's so focal and we can be very specific, we can aim around these plates. Now, if we're dealing with a hemilaminectomy that say distal to that, I may have paraspinal muscle problems, or proximal to that, sure. It's kind of the same thing I do with like chiropractic. I typically will wait at least 2 weeks before I do any kind of, big modalities. I'll probably do laser most of the time if I'm just trying to heal an incision. And then I typically will assess where is there some discomfort and try and go above and below the lesion, because typically most of these guys are okay right over the spot of the lesion, but they're having more compensatory issues. So I'm happy to treat the compensatory issues, but I'm still very cautious. Like anywhere around the incision site, I'm just I prefer personally to use laser. I think that it does, as long as I'm using a deep penetration, I can get that spinal cord healing pretty nicely without oxidative stress. But if I'm treating compensatory above and below, I'm okay with using shockwave on that. But post-op, I'm just very cautious with it, and I'm very specific with it, if that makes sense. Some people have been scared away from shockwave because the patient was sore. I tell my clients, I say, I expect 24 hours of soreness. That's my expectation. So if it goes longer than 24 hours, then you let me know. I also tell them about 20% of my patients are sore for 24 hours. That means that the rest of the 80% is going to feel so stinking good that they're going to go hurt themselves. So you need to keep them quiet and assume that they're sore. So, and that has really worked for me when I have that conversation up front with clients. So when the soreness does come on, they're not surprised. I've had one case that the soreness lasted longer than 24 hours. And you know what? I said, shockwave doesn't work for you. We're going to use something different. But it was one patient in 3 years of using this machine. And we use it at least 5 or 6 times a day, 5 days a week. So it's used pretty good. I'm like, we could go through the normal tissue healing process in like 16 weeks for these tendinopathies to get returned to function. But I was like, honestly, with the shockwave, I'm feeling that they come along a lot faster for me.
But I seem to have better results. I tried to check for myofascial trigger points in the lumbar area as well, like dorsally. So we try and basically apply the treatment dorsally and ventrally to the iliopsoas.
Yep.
I have gone kind of to the minor trochanter area as well, but that's less tolerated.
Yep.
So, and I don't know if it's absolutely necessary. I don't know what your experience is with that.
I do a lot of musculoskeletal ultrasound. So I'm actually looking at these tissues. And so that's kind of helped me. And a lot of the issues we're seeing is actually at the insertion at the lesser trochanter. So that's where a lot of the edema is sitting. So, and that has actually changed the way that I treat this. Like I had a, gosh, how big was it? Like 60-pound dog yesterday that I ultrasounded their iliopsoas. And what I am able to do with the ultrasound is see how deep their muscle is and how deep the tendon is. And that helps to guide me on what size pad I want to use. And I realized that, okay, we're at right about 2 centimeters on the ultrasound. So I, of course, pulled out my 20 pad and I went to town. And because the dog was sedated, I could really get up into the insertion area where the edema was, and then you're going to get insertion apathies, and then you'll also get through the musculotendinous junction right there as well. So I always try and make sure I'm kind of hitting those regions. Something that's actually helped me, and especially because a lot of these guys are going to actually be awake when you're doing the subsequent follow-ups. They're not sedated in this case. But something that's helped me is actually to do a linear treatment through the muscle body, through the musculotendinous junction, and then coming up with the focal probe as if I'm doing a hip treatment. And that's when I use the focal probe and I'll cut it down. So if I've got a nasty iliopsoas issue, I mean, I'm probably on anywhere between 2 and 4. And if they can't handle that, I'll go down like below 0. So, you know, to the points. But I'll use a focal head, and I usually do about a 5 because it's just right there underneath the surface. And I will do a focal treatment right over that lesser trochanter. And that way I feel like that's going to provide the most comfort, because that's usually where the actual problem lies. And that's just since I've really gotten into doing musculoskeletal ultrasound and understood what the pathology is behind some of these, that I felt really comfortable in being able to treat that way. But you're exactly right. Typically, these iliopsoas also have issues with their lumbar spine. So always definitely doing a dorsal treatment with the linear is nice. Also including some chiropractic or joint mobilizations through that lumbar spine. And don't forget to work on some of that hip range of motion as well. And that'll all complement what you're doing with the shockwave.
We've got one dog that has considerable arthritis in the feet and the elbows and the stifles. And that dog requires, you know, the idea that do 4 to 6 treatments and it lasts a while. This dog needs treatments every couple of weeks in order to keep functioning. So we're finding that the really chronic, long duration kind of stuff needs regular treatments. And it just needs more chronic care.
I want to talk a little bit about that because I have found myself settling into that as an offering, particularly for my older cruciate dogs with pretty severe, you know, maybe they're chronic partial tears that we know those stifles are nasty, DJD. And what I find is that the dogs do really good if I amp up the treatment plan. So whether it be between 3 and 6 treatments, that's usually my protocol for osteoarthritis is usually 6, once a week for 6 weeks. And then I jump into about a monthly treatment with these guys. And I judge it based off of how my owners are telling me they're feeling. So a lot of them, and I'm also doing some medical therapy at the same time. So, you know, I tend to, with these chronic guys, we'll use a combination of gabapentin and amantadine in NSAIDs if tolerable, you know, tolerated. And then keeping them on that monthly shockwave. And we took this, I mean, I have this old cattle dog, bilateral cruciate tears. Owners didn't want to do surgery. And he's running in the fields again, but I get him coming in once a month and I'm like, hey, let's just shockwave. And the owners are like, great, let's do it. It's easy. We can come and do that. So I find that the owners see the results and then they really like that long-term plan for their dogs. There's a few people out there that don't. And those are ones I'm like, well, we either do this or we do surgery or you do intense medical therapy. And most of them are like, shockwave's great. Let's do that. So I really like that. The other thing is I see after doing this for a number of years, especially my chronic elbow OA cases, is that I see their OA stop progressing. So it becomes like I'm not necessarily making headway in range of motion, but they're not getting worse if I keep going once a month with these guys and they stay super comfortable. I have a really, really severe OA case. He's actually the one that's in my elbow presentation. And I treat him, we've gone to about every 3 weeks because it makes him feel really good. And he's actually on no medications and he only comes in for every 3 weeks shockwave. And the owners, he's 14 now. So he's just, and he still goes for walks with his parents. And we do like, I do a lot of legs on him. He's probably the most legs I'll actually do. I do 3 legs on him. So I do both of his elbows and then he's got an old TPLO that I treat the stifle on. But he's doing really well. And that's what I want to see. I want to see these guys living their best life you know, and with mobility. And the geriatrics, I think, are really super responsive to that continued care.